Good evening. It's just about 6 o'clock now, so we're going to give it a minute or two and let some folks join. We have some folks that are still coming in, so um, just give it another second or two, and then we'll start our presentation for this evening. Okay, it looks like it's about 6:01, so in order for everybody's time and to be consistent, we're going to get started tonight. Good evening. Welcome and thank you for attending tonight's Ahead of Cancer lecture series sponsored by the Allegheny Health Network's Cancer Institute. My name is Michelle Stanicki and I'm one of the project coordinators for the Cancer Institute. There are a few housekeeping items we would like to review before we start. The first is during the presentation, all participants can type questions into the chat or Q&A portion of the Zoom. We will be addressing those questions at the end of the lecture if time allows. Secondly, participants cannot speak during the conference, but again, we encourage feedback via the chat option. Tonight's lecture is being recorded. If you're interested in rewatching this lecture or any of our past lectures, please check out our AHN YouTube channel. The entire lecture series is posted under the Ahead of Cancer playlist. Lastly, if you'd like to schedule an appointment or have any questions regarding a potential concern, please feel free to call our Hope line at 412-578-4673 to schedule an appointment. And we'll repeat that at the end as well. Tonight's topic is Beyond the Basics, genetics, screening, and cancer prevention. We are pleased to welcome Kyla Morphy and Jenna Rowe this evening. But at first, I'd like to take a moment to introduce these remarkable individuals and showcase the impactful work they're doing right here at Allegheny Health Network. First up, we have Kyla Morphy. Kyla is a highly experienced genetic counselor with a career spanning over 2 decades, beginning in 2004. She started at LabCorp as a laboratory genetic counselor, contributing to report writing and analysis. In 2007, Kyla joined Allegheny Health Network as an oncology genetic counselor, playing a pivotal role in establishing oncology genetic counseling services across more than 10 Allegheny Health Network locations. Her expertise also includes a 3-year tenure at the University of Maryland, where she focused on pediatric and cardiac genetics, founding their pediatric and adult cardiovascular genetics clinics. Currently, Kyla serves as a manager of oncology genetic counseling for Allegheny Health Network, where she continues to drive the growth of the network's oncology genetics program. Second, I'd like to introduce Jenna Rowe. Jenna is a certified registered nurse practitioner with Allegheny Health Network with over 20 years of experience exclusively in medical oncology and hematology. Jenna is passionate advocate for cancer prevention. She currently leads the AHN cancer screening program at the Allegheny Health Network's Cancer Institute, where she had committed to enhancing the early detection strategies and ensuring broad access to essential cancer prevention services. Jenna's academic foundation includes a Bachelor's of Science in Nursing from Edinburgh University and a Master's of Science in Nursing from Clarion University. Welcome, ladies. I'm going to turn this over to Kyla, who will be starting us off with the genetics portion of our topic tonight. Thanks.
Thank you very much, Michelle. Okay. Michelle, can you see my screen okay?
Yes.
Okay. Perfect.
Great.
Thank
Looks
you.
perfect.
Okay. So thank you so much for joining us this evening. Jenna and I are going to talk a lot about how to identify individuals that might have possible genetic markers for cancer. And then, some of those things that we can do when we do identify someone that might have a higher risk for cancer and what they might need to be, more proactive about going forward. I'm going to talk a little bit more about the genetics because obviously that's my area of expertise, and I'm going to pass it over to Jenna to talk more about some of the screening and cancer prevention. So I just want to start off with some things that I hear very often in clinic. Is blank cancer genetic? Am I going to end up like my parents did? My cancer risk is out of my hands. Breast cancer is my destiny or fate. A lot of these statements are ones that we hear frequently, and it's what brings individuals to our doorstep usually to get more information about, what their risks actually are. I always like to take a step back and just talk about that, even if we do find that there is, some genetic marker for cancer, it's never the be all end all answer. Personal cancer risk is a combination of multiple different factors. Some of it, may be family history. Some might be some of those genetic markers. But then there's a lot of things that we don't necessarily have control over, like aging and chance. And then some things that we might have some control over, but not necessarily complete control with, environment, what we're exposed to, and then lifestyle. So cancer risk in general is a combination of all these factors interacting with each other to, increase that risk for cancer. The big difference when we talk about these, genetic markers, and today when we're talking about genetics, we're really talking about those hereditary cancer markers, or those genes that are being passed from generation to generation. It is still a combination of factors. There are not any genes that we know of right now that are really associated with completely 100% risk for cancer. But in these individuals, that section of cancer risk that's related to genetics is bigger. So I always like to tell individuals that, these genetic markers that we look at are just risk factors like other risk factors that we've, know of. These are ones we just happen to be able to pinpoint a little bit better sometimes and maybe even help us guide ourselves better in terms of what kind of screening we should be doing going forward. When in my world of genetics, I focus on a very small portion of cancer. So only about 5 to 10% of cancers are hereditary. Most of them are that, green sporadic section. Those are just those chance occurrences. A lot of those sporadic cancers are the ones that tend to be more age related, which obviously we don't really have control over. And about 30% of cancer falls in this, familial category, where we might see a little bit more cancer than we expect to see just by, chance, but not necessarily finding one of those strong hereditary factors. Of the hereditary factors that we know of for cancer, it's also broken down into multiple different categories. And this has evolved quite a bit over the last even, 10 years. So some of the big genes that many people may have heard about already are genes like, BRCA1 or 2. Sometimes people will have heard of them being described as like the BRCA genes. And then Lynch syndrome genes. Those are more colon cancer related genes, but those groups are ones that we've known about for over 30 years. So we've been testing for those genes for quite a long time. Um, Over the last 10 years, we've started to discover some newer genes that are related to those like hereditary cancers. Some of them are higher risk, like the BRCA1 and 2 and Lynch. And by high risk, we usually mean they're associated with a 50% risk for cancer or above. But then a lot of the newer genes that we've discovered are more in this moderate risk category, where they are associated with a higher risk than we expect to see by chance, but maybe not quite as high as those BRCA genes. And then, of course, in the world of medicine, we're always learning new things. So there are a lot of newer genes that we're discovering, as we are doing more testing. So some of these newer genes we may not have as much information about right now, but again, doesn't mean that in 5, 10 years we won't know more about them going forward. So which individuals do we want to think about if we're kind of thinking about people that might have one of those hereditary cancers? Um, some of the things that I always tell individuals that we're looking at are sort of those rare or unusual situations. I'm always saying if it's rare or unusual, that's when we start to think about maybe a genetic cause for those cancers. So with that being said, one is that if people are being diagnosed, younger than we expect to see by chance. Like we are just talking about, cancer is a disease of aging, so we do see the risk going up as we get older. So if people are being diagnosed younger, it just makes us wonder if there is some, underlying factor there that made that happen at an earlier age. And then kind of going along with that, rare and unusual, if the cancer type itself is rarer or less common, those are ones that do have a little higher risk to be hereditary. So things like, ovarian cancer, pancreatic cancer, male breast cancer, very specific types of stomach cancers called diffuse, and then pheochromocytomas and paragangliomas. All of those, even if we don't see them being young or family history, are enough to, consider at least one of these hereditary cancer syndromes. If there's more than one cancer diagnosis in a person. So again, like cancer can happen at any time, and we can see people with more than one type of cancer over their lifetime, but it's not as common. So if we see that in an individual, again, it's just one of those factors that makes us wonder if there's some, underlying cause there. And then the one thing that I think a lot of people think about, and the part that usually gets them to our doorstep sometimes, is that if there is that family history. So if there are multiple people on, one side of the family that have the same type of cancer, so multiple individuals with like breast cancer or colon cancer, um, or if there's people that are diagnosed with cancers that can be linked together by particular genetic causes that we know of. Um, and so things like, breast and ovarian cancer or like colon and uterine, we know different genes that can cause those types of cancers. So if we see them in one family, again, just makes us wonder if there's one underlying answer for why that's happening. And then, of course, if there's family members also diagnosed at younger ages, and we're seeing that trend towards like earlier diagnoses of those common cancers, it just, makes us wonder if there's something there. Um, the hard part is, and the normal part is that not every family talks about these things. So it is, we try to get as much information as we can, but we do know that sometimes there are gaps in that information, and we do try to take that into account too when we're trying to figure out if there could be something, underlying in the family that maybe just isn't presenting in the way we expect it to, but maybe it's not presenting like we would think because we just don't know about those family members. The way that most of these hereditary cancer syndromes are passed through families is called autosomal dominant. Autosomal just means that both men and women can have these, genetic markers and present with them, and that they can pass it on to the next generation. I feel like this is an important, point just because we care about mom and dad's side equally when we talk about like hereditary cancer. I know that it's, hard when we're thinking about, say, like a more female-related cancer like breast or ovarian, or more of a male-related cancer like prostate, that you tend to think about the other, males in the family or other females. But with these genes, we really can see, men and women equally having, even maybe different presentations, but having those genetic markers. And dominant just means that it takes only, one copy of that gene to not be doing its job in order to have that increased risk for cancer. So it's a little different than some other genetic conditions that people, sickle cell or cystic fibrosis, where maybe, mom and dad both have to be carriers in order for that child to have that condition. With this, that's not the case. Mom could have a gene or dad, and then the kids are at risk as well. Um, the reduced penetrance is something that we're seeing more often, and that just means that you can have that genetic marker, but that we may not see a high risk of that cancer happening. So some of these newer genes have like much lower cancer risks associated with them, which is why I think it took us a little longer to find them. But because some of these genes maybe have, a 20% risk for breast cancer, we may not see that pattern of every generation because, if it's one of those genes, 80% of the time, they're not going to have that cancer that we expect to see. So when we see, family histories, and especially, some of the family histories that we used to see when we thought about hereditary cancers, we used to see families that looked pretty significant, pretty overwhelming, where we did see that pattern of like, we got multiple generations with cancer here. We have, our patient who's 34, so younger with breast cancer. She has an uncle and an aunt with cancer, a cousin with cancer, and a grandma. So we're seeing, a lot of cancer presentations in this family. We're seeing younger ages, and then we're seeing some of those, rare cancer types like ovarian cancer. Um, this family history, I think most of us could kind of look at it and say, hey, there's probably something going on here. The thing that we have learned over the years is that this is not always the family history that we see for individuals that have these cancer genes now. Now that we've tested more people and we've seen more variations, families tend to be a little bit smaller than they used to be. we don't necessarily see as much cancer as we used to expect, which has kind of changed how we test people and how many people we test now. We do a lot more genetic testing based on, less information than we used to. So, who are the good candidates for cancer genetic counseling and testing? A lot of those rare cancers, so ovarian cancer, fallopian tube, peritoneal, anybody that has, that diagnosis or has a close relative with that diagnosis, does qualify for genetic testing. Metastatic prostate cancer. So again, not everybody with prostate cancer because that is a more common cancer in males, but more that rarer presentation, like that metastatic prostate cancer, does have a higher likelihood of being genetic. Pancreatic cancer, male breast cancer. And then there's some other cancer types that are also, fairly rare, like those PHOs, paragangliomas, adrenal cancers, and specific type of thyroid cancer. Not the thyroid cancer that's more common at younger ages, but more this medullary thyroid cancer. So for those cancer types in general, even if there's no family history, we do, consider doing genetic testing. If it is a more common cancer type, what we're looking for are some more of those unusual features related to that cancer type. So, for breast cancer or colon cancer, those are more common in the general population. So again, we're not testing everybody because the chances it's going to be genetic is much lower. But if they do have that, younger onset, so usually 50 and below is sort of our cutoff to say, okay, this is a little younger than we expect to see by chance. Maybe there's some underlying genetic marker there. That also applies for like kidney cancer and uterine cancer. And then, of course, again, if there's multiple people having the same type of cancer in a family, that is another one of those factors that just makes us wonder why this is happening, and if there is some, genetic marker there. Some of the cancer types, that tend not to be as likely to be genetic are ones that we tend to know more maybe environmental or other external factors that might be at play. So things like lung cancer and mesothelioma, we definitely know of some stronger environmental factors that are related to those cancer types. Not to say that there aren't some genes that are also related to a higher risk for those types of cancers, but just less commonly something genetic. Esophageal, cervical, ones that we do know some other, viruses or other, contributing factors. Head and neck, anal, skin cancer. So like the basal cell, squamous cell skin cancers, more those, sun-related skin cancers don't tend to have as strong of a genetic component. If you think about skin cancer and think rare, melanoma is a rare type of skin cancer. And so there are some more genes that we know of that are related to melanoma than there is for those basal cells and squamous cells. And then some of the cancers that look more just, sporadic, just sort of those chance occurrences, like thyroid cancer, the non-medullary thyroid cancers, so the ones that we tend to see, at younger ages of onset, testicular, primary liver and primary bone. All of those are ones that we don't have a lot of strong genetic factors for right now. So how do people end up at my doorstep and what do I do with them? So if someone, has a diagnosis of cancer, especially one of the ones that we were just talking about that are more likely to be genetic, or has a family history of one of those types of cancers, or like multiple individuals with the same types of cancers, they usually get referred to us or could be self-referred. And when they come in, we go through their medical history because we want to know what's happening right now. What kind of screening are we doing? Is there anything that we would need to change going forward if we did find one of these genetic markers? And then we take an extensive family history. So I always tell people I'm lucky. I have a lot of time with patients to go through, and ask about every aunt and uncle and every cousin and grandparents and even great grandparents if we know, to see, if there is that pattern of cancer in the family. And depending on what we see in the family history, it might point us in different directions in terms of genetic testing, and what genes we might want to make sure we're getting covered, in what that information could tell us for that individual or their family. So we do talk through sort of all the pros and cons of testing. And if someone decides they would like to do genetic testing, then we'll collect a sample, send it off to the lab to be analyzed, and then I'm the one that would also call the patient with the results and go through, what we found, what we didn't find, if there is some genetic marker, and what that genetic marker means in terms of cancer risk for them, and then what we should do about it. Is there increased screening or surveillance that might be helpful for that, individual or family? I know not everyone has this, but we usually spend an hour with patients. So we do have a lot of time to kind of talk through all of this information before even starting to do genetic testing. Um, and I know I was mentioning genetic testing, and I feel like it's become, much more commonplace these days. So a lot of people have kind of heard about it, just, whether it's on the news or media or whatnot. But just wanted to kind of run through, quick biology overview of what we actually look for. Um, so all these, different genetic markers that we know of are ones that, typically these genes are good. And these genes are typically like tumor suppressor or cell cycle checkpoints. The role of these genes is to prevent cancer. So like these BRCA genes and these Lynch genes I mentioned, they're good when they're working. They prevent cancer in our bodies. So when we do genetic testing, the lab is just kind of zooming in on the genes that we tell them that we want to look at based on, what we discussed in their family history, and reading through that genetic code letter by letter. If everything is spelled correctly, then we go, great, these genes are working. This is not the answer. You don't have a genetic factor for cancer, that at least we can find right now. And then if we do find something that's spelled wrong, well, that gene's not doing its job. And that's when we can see that higher risk for cancer. So really the genetic testing, sort of the bottom line is it's sort of spell checking your genes for you, just to make sure they're actually spelled the way they're supposed to and telling our body to do what they want it to do. So I was like, why do people want to know, whether or not they have a hereditary factor for cancer? Um, you know, a lot of people just want to know, like, what is their personal risk to get cancer? I'm kind of going back to the question that I mentioned in the beginning, where people will say, I just know this is going to happen. Well, maybe not. Maybe there is some genetic factor in the family that you just didn't inherit. So people might want to know their personal risk for cancer, or if they've already been diagnosed, what are the chances that they're going to get another cancer? Um, Children's, risk to get cancer. A lot of people are doing this information for family members, and then other family members' risk to get cancer. I'm going to leave some of this for Jenna to talk about, but a lot of what we can do when we get results is figure out if there's some, screening or prevention that is available for them based on what we found. And it may help, find and detect cancer early, or even prevent it if we can, and save someone's life. Another question I get a lot of, when we do have this discussion about like the genetic testing and why people want to know is sort of why would I not want to know? Um, and some people don't want to know because they're worried about insurance discrimination. Um, and this is definitely something that we talk through with all our patients as well. It is a medical test. The results are going to go into the medical records. And so, other people in on their healthcare team or other doctors we will be able to see those results. I know some people have asked if they can hide them, and we can't. Once they're in the record, I would, always worry about not telling someone about all the details, because somebody's going to see it and someone's going to tell you. I'd rather, have you have the full information up front, and know, what this is and what it can tell, you going forward. Um, in terms of discrimination, there is a law. It's called GINA, the Genetic Information Non-Discrimination Act. It actually made it illegal for health insurance or employers to use genetic information to discriminate against. So it does cover a lot of what people are concerned about in terms of like their health insurance and employer. The things it doesn't cover, though, are any of those like sort of bought into insurances, like life insurance or long-term care. those insurances can still ask pretty much whatever they want to, and use the information however they want to in determining rates going forward. So if someone does decide that they want to do genetic testing and we get their results back, I always kind of think about it in affecting three different sort of categories. So how can it change, treatment and management? One is that if it is someone who's diagnosed, it could change, chemotherapy selection and prognosis. So for someone who's going through cancer, it may be able to give them more information about, different treatments that may even be beneficial if they do have a genetic marker. Um, for people, it can give us information about like surgical management and, recurrence risk. And then other cancer risks. So sometimes it does sort of open up Pandora's box a little bit and put something on the radar for, the patient or family that wasn't necessarily on the radar beforehand. But when we get those results back, anything that we can see with it, is something that we need to think about going forward. So I'm just going to go through quick example of some surgical management. And of course, wanted to use one of the genes that I feel like most people have probably heard about at some point. So these are the BRCA1 and BRCA2 genes, so the BRCA genes. These ones we've been testing for over 30 years. So we have a lot of information on them, which is really helpful. These are the ones that, you probably have heard about that are associated with like breast and ovarian cancer in women, and then male breast cancer, prostate cancer in men, and then pancreatic cancer and melanoma in both males and females. So sometimes if someone does find out that they have, a BRCA1 or 2 mutation, they may take some more like, preventative measures. And again, these are not things that people have to do. It's just, information to help them in making their decisions to decide what's best for them. But for people with BRCA mutations, who are unaffected, they do have a fairly significant increased risk for, breast and ovarian cancer. So for females, the breast cancer risk can be, up to 80%, and for ovarian cancer, up to 45%, just depending on, their age and what gene it is. So some people will choose to do, preventative mastectomies, just to bring that breast cancer risk down as much as it can. And they think it reduces it about 90 to 95%. And then having ovaries removed, which also, taking the ovaries out removes that risk as much as we can. Nothing is ever 100%, but definitely brings it down substantially. And then sometimes there's different medications that people can take to kind of reduce their risk for cancers. Like tamoxifen is something that a lot of women take, after a cancer diagnosis to help reduce the risk of a, recurrence. But it also is something that women can take before developing breast cancer to help reduce the risk of ever having it. And then oral contraceptives actually helps reduce ovarian cancer risk if taken for a certain length of time. I know that I mentioned that things have changed a lot over the last 10 years. And so, although I use BRCA1 and 2 as our, examples for some of these screening, there are a lot of other genes now that fall into these categories as well. So, any of the genes that are associated with that, like over 50% lifetime risk, do have that option to consider, preventative surgeries in terms of, preventive mastectomies, or having ovaries removed for any of the genes that are related to ovarian cancer. If people fall more in that moderate category, or some of the newer categories where we don't really know the exact, say, breast cancer risk, sometimes we're just doing increased screening with the goal of detecting things early, which I'm going to let Jenna talk a little bit more about. But all of these genes do have different guidelines, either in terms of like increasing screening or considering like preventative surgeries to kind of reduce the risk as much as we can. So other cancer risks. This is where I always am telling people kind of opens up Pandora's box a bit. But, when we think about hereditary colon cancer, so sort of switching gears, Lynch syndrome was another one of those genes I mentioned in the beginning that we've known about for a long time. It was discovered in the 80s. So it's been a very long time that we've known about some of these genes that are related to, genetic colon cancers. And some of the genes, some of the cancer risks that we knew about originally were ones that were more those like colon and uterine cancers. So these are cancer types that we tend to think about for Lynch syndrome. But if we test somebody and find out that they have a Lynch gene, here are all the other cancer types that we know people might have an increased risk for as well. So these are things that we don't typically screen for or don't usually have surveillance for um, in the general population. But if we find out that someone has one of these genetic markers that's also related to these cancer types, then we want to put them on the radar for the family and discuss, screening options and trying to detect anything at an early stage, if there were ever to be anything for those individuals. And then chemotherapy, selection and prognosis. One of the biggest areas that we, think about with this and that we started doing research for, first was in pancreatic cancer. So there are a lot of genes that actually are related to pancreatic cancer as well. You'll see down here this hereditary breast and ovarian cancer, so that BRCA1 and 2 again. Um, and they found that there is actually an increased survival for patients with pancreatic cancer that have BRCA1 and 2 mutations or PALB2 mutations that receive specific, platinum-based chemotherapies. So they found that those types of chemotherapies actually work better for patients that have those particular underlying genetic risk factors. Um, and then also looking at, PARP inhibitors for those that group of individuals too. For individuals that have like microsatellite instability or mismatch repair, which are some of those Lynch genes, they found that immune checkpoint inhibitors work better. And then, for VHL mutations, which is more like a kidney cancer related gene, also specific chemotherapies that, can be better for those individuals. I kind of think this is where a lot of, medicine's going. We're going to treat people a little bit more specifically based on, some of the underlying factors of why that happened. So it's always an exciting time in the world of genetics, but wish I had like hours to tell you about all of these things, but just like to kind of point out some of the things that are coming down the pipeline. I'm going to turn it over to Jenna to talk a little bit more about that screening and surveillance. And I know Michelle mentioned that, we're always available. So we do have now 8 different locations that we see patients at. So if anyone, wants to come and talk more about these things, you are welcome to call to schedule an appointment with us. And Jenna, I am going to stop sharing and hand it over to you.
Okay, good evening. Can everybody see and hear me?
Yes, we
Okay,
can.
Yes.
wonderful.
Yes, we can.
Okay, just wanted to make sure. Let me get my screen pulled up here. And you guys are able to see my slides, correct?
We are.
Okay, wonderful. All right, Michelle, thank you so well. Let me thank Kyla first. Kyla, that was a great presentation. Thank you so much for kicking this off with the genetics um, little refresher there. That was good information for everybody. And then I also would like to thank Michelle for that great introduction. I want to expand a little bit more on just introducing myself and kind of my history as a nurse and how I have come into this role. In 2001, so 25 years ago, I started as a floor nurse in medical oncology. Had a family history of several relatives with cancer, which kind of brought me to wanting to be in medical oncology. Was a floor nurse, then an outpatient chemo nurse, then decided to go back to get my nurse practitioner degree and then joined the group as a nurse practitioner. So all 25 of my years have been in medical oncology. The last several years have really focused on breast cancer. And, when you see patients come in with breast cancer, you see those who detect their cancer early and they're a stage 1, and you see those who unfortunately present to us with a stage 4 cancer. And we know that stage 4 cancers, at present time are not curable, but we have great treatment and we can certainly extend life longer than we could 10 years ago. But those stage 4 cancers are those tough ones. Those are the tough ones where you have tough conversations with patients about their diagnosis. And seeing those stage 1s are more of those good outcomes, those patients who we know that we can cure and they can go on and live their life and cancer can be behind them. So with our cancer screening and outreach program, we really focus on that early detection, finding those cancers in a stage 1. So when this opportunity to transition to this position became available, I knew that was where I wanted to be. I wanted to be able to get the word out there for early detection, early screening, make sure everybody's on track so that we can, if we're going to catch cancer in that early stage, that stage 1, where we can cure, where we don't have to talk about, end of life because you have a later diagnosis and treatment will eventually stop working. So really passionate about being in this new role and really spreading awareness for early detection and cancer screening. So just wanted to expand a little bit about, why I'm in this role and the positive that we can really spread with this program. Let me move to just some cancer statistics. The World Health Organization reports that cancer is the second leading cause of death globally, accounting for an estimated 9.7 million deaths in 2022. And in 2022, there were an estimated 20 million new cancer cases globally. The most common cancers globally include our lung, our breast, our colorectal, prostate, and stomach cancers. And like I talked about, survival rates vary significantly depending on the type of cancer, the stage at which it is diagnosed, and the effectiveness of treatment. With that being said, early detection often leads to a better prognosis. So catching those cancers in that early stage 1, good prognosis for patients. United States statistics, it was estimated that there were over 2 million new cancer cases diagnosed in the United States in 2024, and cancer remains the second leading cause of death in the US, with over 600,000 cancer deaths estimated in 2024. About 1 in 3 men and 1 in 3 women will be diagnosed with cancer during their lifetime in the United States. The most common cancers by new cases in men are prostate, lung, and colorectal. And then in women, we see it most commonly in breast, lung, colorectal. And then the most common causes of cancer deaths are lung, colorectal, and prostate in men, and then lung, breast, and colorectal in women. And a significant portion of cancers are preventable. There are risk factors that increase your risk of developing cancer in your lifetime. Those include, or can include, tobacco use, alcohol consumption, an unhealthy diet, physical inactivity, obesity, certain infections like HPV, hepatitis B or hepatitis C, and exposure to environmental pollution. So talking a little bit about our cancer screening and outreach program, we are a small but mighty group. We have weekday clinics at our Mellon office, our Jefferson office, and our Forbes office. Mondays we go to Mellon, Tuesdays we go to our Jefferson office, and every Wednesday we go to our Forbes office. We do full clinic there with up to 7 screens. Then we also offer our weekend clinic, which is 1 Saturday per month at rotating sites throughout the network. You will see us as far as St. Vincent doing a cancer screening event, Grove City, and then locally with Allegheny General, Allegheny Valley, Hempfield, Jefferson. We try to hit all the regions so that we include everybody around the Pittsburgh area and outside so that they're able to get their cancer screenings. On our Saturday events, we can see up to 100 patients at that Saturday event. And then we also have community outreach programs available. Key concepts of cancer screening is really screening those asymptomatic patients, those patients who may be behind on their screenings. They're 48 and their last mammogram was done at age 42 and they just need to get caught up. We get them in the door, we get them screened, and we get them back on track. We can detect cancer early by doing the screenings. And abnormal results, we certainly follow up timely with all those results and get you squared away with where you need to go as far as referrals. The screenings that we offer at our weekly clinic or our weekend events include skin cancer screening. We're able to screen anybody age 18 or older. We do then recommend you annually be screened for any type of skin cancers. At our events and weekday clinic, we also have the ability to use a handheld Vectra, which is using AI technology where we can screen a mole or a suspicious lesion on your skin, and it can give us a risk assessment that lets us know what is the likelihood of this being a cancerous lesion. Should we do a straight referral to the dermatology or the skin center for further evaluation, or is this something that we can just watch? And we have that ability then to, on a yearly basis, when you come back, we do comparisons of that lesion that we screened. We also offer head and neck cancer screenings, and we recommend those. We can do those for anybody 18 and older, but is definitely recommended for those who are heavy users of alcohol or tobacco, or any of those with a history of head and neck cancer. We also offer lung cancer screenings. We follow the USPSTF guidelines. Patients, have to qualify for a lung cancer screen with a CT scan. A lot of times patients will want them because they had secondhand smoke exposure, or they have a history of smoking cigars, or maybe smoking marijuana. But there are guidelines that we have to follow in order to do a low dose lung CT. You have to be between the ages of 50 and 80, and you have to be a current smoker or somebody who has quit less than 15 years ago. And your smoking has to equal at least a 20-pack year history, meaning if you've smoked for 20 years, you have to have smoked at least 1 pack per day for 20 years. Or if you smoke for 10 years, you have to smoke at least 2 packs a day for 10 years. We use a calculation to figure out that pack year history. And if you qualify, then we're able to order you that low dose lung CT. For patients who are a little bit hesitant on either the radiation exposure, just nervous about having a CAT scan done, if they meet those guidelines above, we are able to order them what is called Delphi or First Look, and is a simple blood draw where you just have a tube of blood, we send it out, we get results in about 10 to 14 days. Results are straightforward. It's either a yes or a no, meaning yes, you need further screening with the low dose lung CT, or no, your risk of having a lung cancer is low based on those results. We also recommend and are able to offer breast cancer screening following the NCCN guidelines. Annual mammography is recommended starting at age 40. High-risk patients, we can also add an annual breast MRI. And we really recommend that risk assessment starts by age 25. We're having conversations with your doctor when you're going in for your yearly gynae exam. They should be doing a breast exam at that time, talking about risk assessment starting at age 25, but really getting in with the annual mammograms at age 40. Also recommended and offered at our clinic is the cervical cancer screening. The USPSTF guidelines recommend that we start pap smears at age 21, and those should be done every 3 years from age 21 to 29. And then starting at age 30 to 65, we can do HPV alone every 5 years, or PAP every 3, or co-test every 5 years. Always depending on your history of PAPs. If you've had positive or abnormal pap smears in the past, then the frequency of how often we check that PAP is less. This also aligns with NCCN guidelines. And, if you have adequate screening where you have so many negative pap smears in a row, we can discontinue doing your PAPs after age 65. And although I do want to add to this one slide, although it says PAP every 3 or every 5, you still should be seen on a yearly basis with your gynecologist. Doing just a pelvic exam can be discussed at that time. Also doing a breast exam at that yearly visit is recommended. So some patients get a little confused when they hear, oh, I only have to go back every 3 years or every 5 years. We still recommend that annual visit just for the discussion. Make sure that you're not symptomatic or that pelvic exam is normal. Prostate cancer screening, we tend to follow the NCCN guidelines, the guidelines here on the bottom in our screening clinic, meaning that we start screening at age 45, 40 if you're a higher risk. And it's really a conversation between your provider and you as the patient with, is a digital rectal exam necessary, or can we go straight to the PSA-based screening? In most cases, patients choose to have that PSA-based screening, and that is a simple blood work, a blood tube that is drawn. And based on those results, we either repeat your PSA every 1 year or every 2 years, or if it's elevated, we would take next steps. But we do recommend starting that screening at age 45. And then we also can offer colorectal cancer screening. The current age to start your colorectal cancer screening now is 45. Some patients are still on that age 50, but those have been updated, and the recommendation now is to start at age 45. Acceptable testing is a FIT annually. Stool DNA every 1 to 3 years, most often known as Cologuard, or a colonoscopy. I wrote here every 10 years, and that's 10 years if you have a normal colonoscopy. Sometimes that colonoscopy can repeat in a year, a 3-year, or 5-year based on your results of your colonoscopy. NCCN also follows, those guidelines above. And what do we do in our clinic? So certainly we track any abnormal results. We follow up with you immediately. If we find something that's abnormal, you will get a phone call from us. We will make the appropriate referrals if needed. We would coordinate any type of diagnostic testing. Say you had a mammogram that come back. If a mammogram came back abnormal, then we would order a diagnostic mammo and ultrasound, or order you a biopsy if needed, and then make appropriate referrals if any of that comes back positive. We always, communicate either via the MyChart app if you have normal results, or we'll always call you with anything abnormal. But there's always close follow-up and great communication with our patients to make sure that they're taken care of. And really, the key takeaways in cancer screening and prevention is that screening can save lives. Like I spoke earlier, we really want to catch those cancers in an early stage, those stage ones. USPSTF guidelines, population screening, and NCCN guides are high-risk oncology care. So, we use a combination of both of those guidelines in our clinic. We don't just follow one set of guidelines. We kind of use a combination and screen those patients. And early detection improves your outcome and also will reduce any, healthcare costs. And then lastly, I just have a picture here of our team, our director, Margie Leslie. I'm there in the middle, and our project coordinator, Michelle Studnicki. Missing from our photo is our physician lead, Dr. James Bettler. We will certainly get him added to the next time we have a group photo so that we can highlight him also. So that's just kind of an overview of our recommendations for screening and what our clinic can do. You can make an appointment by calling in or using the MyChart app, but we're here to really get your cancer screenings caught up and get you on the right path to getting screened on a yearly basis so that we can detect cancer if we do at an early stage. Hopefully we don't detect any cancer and we just see you on a yearly basis and make sure everything is well. All right, and that is the end of my slides.
Thank you, Jenna. And just to reiterate, the phone number, if anybody would want to schedule an appointment, is 412-359-6665. And I believe we have that on a slide as well. Looks like we have a couple questions, so I'm just going to read the questions. Let's see. The first one is, I am 30 years old. Many of my friends and people I know have or have had or going through breast cancer. Plus, I have a family history. I am nervous. What would you suggest for younger women like me who do not qualify for a mammogram? I don't know which one you want to take that. I don't know if that's a genetics or a cancer.
I feel like it's a little bit of both. So
yeah, I was going to say it's both of us. So
it is.
Kyla, if you want to start, and then I can answer too.
Yeah, so I think, one option would be to start with like that genetic evaluation, because if, depending on the ages of cancer and the diagnosis, and if we do find some genetic marker, it could change the screening recommendations on when we do start that. Some of the genes that we know about, the recommendations and the guidelines that we follow that, Jenna was mentioning, like those NCCN guidelines, start mammograms or breast MRIs at 25, 30, 35, just depending on, what the gene is, and if we do see that like earlier presentation. So that might be a good starting place. Even if they don't do genetic testing, we can also kind of look at the family history and do some risk assessments just based on family, and personal risk factors to see if they do fall in that, higher risk category that Jenna was mentioning too, that, might qualify for breast MRIs or, earlier or additional screening.
Yes, and just to add, but that is correct. That's all correct. And as far as we would want you to get screened genetically to see if there is that risk. But going in, making sure that you're caught up to date with your gynae exams, where they would also be doing a breast exam. You would be having those done on a yearly basis. That would, certainly a clinical breast exam starting at age 25 would be the recommendation, in addition to some genetic counseling. And if there's ever anything abnormal on a clinical breast exam under the age of 40, we are able to order you a diagnostic mammogram or ultrasound if we find something abnormal on a clinical breast exam in patients under the age of 40. Any other questions, Michelle?
Yes, we do. Okay, next question. Are there online genetic tests that people should question completing? Oh, okay. I think this is more, are the online genetic testing adequate? How about that one?
I was like, I think I see where that question's
Okay.
going. Yes, there is definitely online genetic testing, depending on where it's going through, is very different sometimes than clinical genetic testing. So there are a lot of places like, 23andMe is one that we see a lot of, that people maybe have completed some genetic testing through them, and they do some genetic testing for some of the cancer genes. They actually do, some analysis of BRCA1 and 2. But all of those are recommended to be repeated at a like clinical genetics lab before we take like actionable changes. So I always tell people, yes, they're interesting, but maybe not the testing that you would be using to actually change like your medical management. So, and that applies for most of the online ones that are ordered not through a healthcare provider.
And some of those can be costly too.
Mm-hmm. Yes, yes. There are some out there that are many thousands of dollars,
Mm-hmm.
and some of those ones are ones that we have repeated testing and have found that they were not correct in their initial testing. So definitely, take it with a grain of salt. But maybe if you're really worried about it, we can do some clinical genetic testing.
Okay, and this may be our last question. What is the goal of cancer screening? Is it prevention versus early detection? I'm not
Yes,
sure.
so I can answer that one. So in our screening clinic, it's a combination of both. We want to focus on early detection and prevention, as far as having conversations. If patients come in who are tobacco users, we talk about smoking cessation so that we can help guide you in quitting. We have quit lines that we can get you in contact with so that we can hopefully have you quit and then prevent you from getting a lung cancer. We also can talk about, healthy diets and what we need to do with lowering that risk. So the cancer program works on both. At our screening events, we're going to have those conversations with you about prevention and also early detection.
Okay, we got a few more. Okay, so a few more questions. How does Pittsburgh cancer rates compare nationally and in what areas?
That is a good question. I don't have the
I
exact
don't
answers
either. I was going to let you
for
take this
that.
one, Jenna.
I can tell you that I grew up in an area where we had a nuclear waste plant, and I lived in between both of those. So, again, what brought me to work in the cancer field is I had seen such a high amount of family members and friends who are from that area diagnosed with cancer. So it would be interesting to find those statistics, and I'm sure they're out there, and I could certainly get those. I wrote down your name here, and I can get in touch with you after we find out those rates. But there certainly are environmental risk from some exposures of just the surroundings of where we live.
Okay, next question. I am a 65-year-old female, had breast cancer at 35, had a double mastectomy and tamoxifen only for prescription. 15 years later, I got breast cancer again in the same location and had surgery, radiation, and hormone blockers. Now, 15 years later, I wonder if there's testing wise or anything to catch any new breast cancer.
So I think maybe this also might be one for possibly both of us, but you're right. That is definitely given the age of diagnosis of the first breast cancer, we would consider that possibility of a genetic marker there. And there definitely is quite a bit of genetic testing, even if it was done originally. So if that was like 30 years ago, if there was genetic testing performed, it would have just only been BRCA1 and 2 because that was all that was, on the frontier back then. So definitely would be additional like updated genetic testing that we can do now that might give us information about, second breast cancer risks. And usually when we're talking about genetic markers, it's not a, recurrence of the first one, but like a brand new primary, in the same or a lot of times the opposite breast that, we might be able to get information on. If genetic testing is negative, then we're kind of back to where we are now. And maybe wouldn't have as much information, but definitely, some screening that maybe Jenna can talk about or what they do in those cases. Um,
Yes, I agree with that recommendation. It sounds like this was likely a new breast cancer primary, not so much a recurrence of the previous, depending on your HR status, including your HER2 status. And I would recommend definite genetic screening to see if there's any risk there.
There's a follow-up question to the original question. It is, and what are the chances of getting uterine or ovarian cancer as well?
and was that for the breast cancer?
That was for that question, the breast cancer, the
Oh,
question we
okay.
just had.
Yeah.
The question we just had, she had
Yeah.
put another
No,
question
no,
in.
good question. So ovarian cancer, if there is no family history of ovarian cancer and no genetic marker, then ovarian cancer risk is the same as general population. So no increased risk over the general population risk, which is, usually about like 1.5 to 2%, so pretty rare. Uterine cancer could be a little bit different story because I think this patient was on tamoxifen, which may increase uterine cancer risk. So not necessarily related to like genetic factors. There's not many genes that would increase the risk for uterine, but more it would have been just that increased risk from like the tamoxifen use.
Okay. And our last question, I think Jenna, you might be able to answer this, right? I think this just might be an insurance question. My husband had a PSA blood test that the doctor said insurance would cover, but our insurance denied. What should we do? I think a
I
lot
would
of
first,
times, yeah.
go ahead,
I was
Michelle.
just gonna say, I think a lot of times that maybe it might have been a timing issue.
So again, you have to look at the age of your husband, make sure that he's over the age of 45 when the testing was done. And then also the frequency of the PSA. Was this his baseline PSA? Was this a follow up PSA? If your PSA is less than 1, we check it again in 2 years. If your PSA is between 1 and 4, we can check it again in 1 year. So it really, I'd have to look kind of at your husband's history to give you a perfect answer. But I would definitely call the insurance, and the insurance can help you in determine, was it done too soon? Was the coding just wrong? Sometimes I've seen things get denied because we submitted the wrong diagnostic code on that lab. It might not have checked all the boxes, and it just is something as simple as submitting the correct diagnosis for that to get covered. So start with calling the insurance and finding out, why was it denied? What can we do to get it covered?
I was thinking that too, Jenna, because I'm like, maybe if he was a little bit younger than, the typical age, but because it was family history and he was higher risk, maybe they just didn't code it as that
Yeah.
to get it covered.
As simple as a code. We just got to
Mm-hmm.
send them the correct code and it gets paid for. But I would start with the insurance.
Okay, ladies, those are all the questions. We had some very good questions tonight. So thank you for all who put questions in our chat in our Q&A section. This wraps it up. Let's see if there's no other questions. We want to thank everybody for attending the Head of Cancer lecture this evening. Please continue to join us at our monthly Ahead of Cancer lecture series as we focus on cancer screening, early detection, treatment, and survivorship. As a reminder, tonight's lecture was recorded. If you're interested in rewatching tonight's lecture, please check back on our AHN YouTube channel. In front, there should be if everybody can see, there is a slide that gives the information on where you can find the information. And you'll find past lectures there. This video, as well as all other past lectures, are posted there as well. This one will be posted probably in about a week or so up to that channel, so you'll be able to rewatch this as well. Lastly, I would like to really thank Jenna and Kyla tonight for the great presentations tonight, and thanks to all who attended this lecture. Thank you, ladies. Everybody have good evenings.
Thank you.
Thank you all. Bye-bye.